So for my portion of the talk, I'm going to kind of go into the nuts and bolts of key considerations for developing a program, and then probably even the more important pieces for new and emerging programs or programs perhaps choosing to take on a new population. It's where do we find resources to help guide us so we're not reinventing the wheel. And as you'll see throughout the slides, the good news in all of this is that there is a lot of information out there for programs. So my hope is over the next 25 minutes or so to kind of highlight some of the guidelines that are out there, as well as some of the publications that have really been helpful to myself and other programs to really spark some thoughts into how to make mindful decisions as you're creating your program. Beyond the three sites or the three articles that I've cited here, in 2019 alone, there was about 1,700 articles published that covered ECMO. So a lot of information out there for the groups to be able to discover. So as we pop into really the essential hospital components, ELSO guidelines for ECMO centers really do try to hone in on how do you maintain safe delivery of ECMO services. And in part of that is really understanding the geographic location that you are in order to try to support a minimum of 6 ECMO patients per year. And that really is, I stress, the minimum of 6 patients. The cost effectiveness of providing fewer than 6, combined with the lack of clinical expertise associated with treating fewer patients, really should be taken into account when developing a new program. ECMO centers should be located in tertiary care centers. So a lot of thought into where you are physically located can really help guide some of those initial discussions of should we start an ECMO program at our center. Some of the general structure components for a high-quality program, it is recommended to be able to put a single physician director in charge of this program. Their responsibility really will be the overall operation of the center. While there may be several associate directors with a specific interest or focus in limited areas of ECMO care, that primary ECMO medical director should be responsible for assuring appropriate specialist training and performance, directing quality improvement, projects and meetings, and assuring proper and valid data submission to really help round out a high-quality program. An ECMO coordinator or ECMO manager, they really have the responsibility to supervise and train the technical staff, maintain equipment, and collect some of the patient data related to caring for these patients. Also included is a multidisciplinary team, and as well, we'd be remiss if we didn't also touch on the formal policies and procedures associated, covering some of what Dr. Zakhary mentioned in terms of indications and contraindications for ECMO, things like clinical management of the patient, management of equipment, and as well follow-up of the ECMO patient care. So 2 of the positions that I mentioned were the ECMO coordinator or manager and medical director, and a lot of times it's, really trying to tease out who's the roles and responsibilities of these 2 individual roles. Medical directors having a focus in that quality of clinical work, patient care standards, referring provider relationships and provider coverage. And then over in the manager's domain, more of the operations, capital management, planning, staffing models, equipment management. But the design of this overlapping circles are intentional, as there's a lot of work that needs to go on beyond this DYAD that overlaps a lot of these elements, that there needs to really be a nice synergy between the goals of what the program's trying to achieve and these roles of the manager and the medical director. So as I alluded to in the first elements of really trying to make that decision for new programs, should we start a program, it's really understanding your geographical location. That needs assessment to define, really what is the role of this program, not only in your institution, but within your local medical community, as well as defining what population you're looking to serve. The demand for that service is so imperative. And so on ELSO.org, there is actually a ECMO center registry that does show all the different centers that are located. And as of today, There's about 47 states across the U.S. that have established centers. As well as you can see from the map, there is now chapters established in every continent throughout the U.S. With individual chapters through Euro-ELSO, Asia-Pacific, Latin America, as well as Southwest Asia. So part of that discovery phase of starting a new program would simply be look in your state and look in your neighboring states to figure out where those programs are located and what populations that they are serving. The different colors associated here can be the different populations, meaning some programs are neo-peds only, some are adults only, and really having an understanding of how far away those centers are located from your institution. A piece of literature that I have been found to be often very helpful in discussing setting up and maintaining an ECMO program was this piece published in 2013 in Pediatric Critical Care. And, you know, they really talked about the essential components required to build a ECMO program, and those things being motivated experts, having a strong institutional commitment, and an interprofessional team of healthcare providers with dedicated time, space, and resources. And through this article, they walk through these 6 steps as defined that you can see in this chart here. You know, so covering things is in terms of even the planning phase. So when considering starting up that program, you know, have you identified key personnel? Have you done a needs assessment? And really thinking about that strategic plan for your program. What is the next 1, 3, and 5-year plan for developing this critical ECMO service? As you start to go into the development phase, resources that are going to be required to support a service like this need to be identified early and projected over the time span of your strategic plan. Not to be remiss in looking at components such as resources as organizational resources, human expertise, and equipment. Falling into implementation phase is a rather big emphasis on education and training. These truly will be the key determinants of success and sustainability of a program. The level of education required will be determined by the existing expertise and in-house ECMO team. You should not simply assume that because an individual has practiced ECMO in another institution that he or she will be well-versed in the therapy and or technologies that belong and that are being introduced locally. And I think that's a piece that I constantly stress is one ECMO program is not necessarily like another. And so this is, you know, in my opinion and in my, an area that I'm very passionate about is making sure that that training and education is very much solidified within an ECMO program. So once implemented, ECMO programs obviously must focus on that sustainability. It relies on continual clinical demand, growth of patient populations, as well as your ability to demonstrate competency, continuous monitoring, and reporting of outcomes. And then rounding out towards evaluation, you know, ECMO is a high-risk, infrequent, and complex therapy. It is applied to the sickest of patients, many of whom would likely die without it. Complications are frequent. They can be minor. They can be life-threatening. They can be fatal. And so being able to really have a mechanism to evaluate how your single site is performing compared to others is of the utmost importance, in having that ability to have benchmarking data. And I also will touch on the last piece, which is moving forward, and under that you can see research and innovation come in there. And I know for non-academic institutions, sometimes it's hard to sell on the research piece. However, you know, all programs are going to encounter programs, and they're going to have to solve them on a regular basis with new ideas and solutions. And what has really been at the bedrock of the ECMO community is being able to share those experiences. And so perhaps it's not research in the conventional term, but this is a fundamental need that needs to continue to be shared and discussed throughout the ECMO community. So as I mentioned, this team training and education is a huge component. You know, each center really should have a well-defined program for training, certification, and recertification, in which every member of the ECMO team should complete this program. And that goes back to the piece that I said is, just because someone has previous experience does not really shouldn't grandfather them into a local program clinical daily management. Every team member should really go through a program. You need to be able to have routine continuing ed opportunities available. Emergency training opportunities should be outlined, recorded, and documented in the participation, as well as a recertification process for team members not involved in pump management for greater than 3 months. And this is where that piece of, if you are in a lower volume program, the opportunity to have constant pump management does begin to wane. And so thinking about how you're going to keep your team's skills and competency up. These pieces become even more so important as you talk about regulations related to healthcare delivery. So as I also mentioned, there's a lot of resources, not only in the publications I've referenced, but ELSO did produce, I believe the last iteration of this one was in 2014, and more guidelines to be updated to be coming. But this is a guideline on training and education, so it's a step-by-step process that shares the not only what I just shared in the previous slide, a kind of a general outline of what programs should look like, but even going so far into explaining the core curriculum and what topics really should be covered. For the purposes of training and for the purposes of the guidelines, the ECMO specialist really is this technical specialist trained to manage ECMO systems and the clinical needs of the patients under the supervision of a licensed ECMO provider. And with this, ELSO has outlined some criteria around basically 4 major healthcare professionals, which is, right now in the U.S., nurses, respiratory therapists, perfusionists, as well as physicians really fulfill those roles of an ECMO specialist. In terms of course design, we are looking for anywhere between 24 and 36 hours of didactic delivery for these local training programs. Case presentations are always encouraged with the adult learners involved. And then as well is a simulation lab or wet drill component to what education should look like for training for these, managing these patients. These sessions should allow for a small enough group that individuals have that hands-on experience and can have a full understanding of navigating all major circuit emergencies and appropriate interventions. Really by the end of each simulation lab, the team and the individual should feel very competent and comfortable being able to navigate that wide array of issues that can occur. Also, there's a lot of information out there for those of you who are more prone to digest your information through social media. There's a couple handles at the bottom, whether Facebook or Twitter. There's sometimes daily, if not by the hour, information that comes out. There's a subgroup through the Extracorporeal Life Support Organization called ECMO Ed that really has been talking about how do we standardize education across the globe, with really kind of these 5 categories outlined to the side here. Trying to define criteria for these courses and maintaining a vehicle for delivering a standardized curriculum. So I would encourage everyone on the call to consider jumping on these social media accounts and following the work that's to come, because it's been pretty exciting to see almost a daily development of new information coming out from across the globe on this topic. As well, in timeliness to this, and as Dr. Zakhary mentioned, really since 2009 there has not been a pandemic that's really gotten our attention. I know personally, and Dr. Zachary's on the same WhatsApp chat that was going off all night, that there's a lot of eyes going on the coronavirus right now to figure out what exactly is going to happen with that, and a lot of preparedness and anticipation if there is in some way, shape, or form that it begins to mimic similar to what H1N1 did in 2009. So for those of you interested, for those of you perhaps on the call that are in a biocontainment center, like myself, we have pulled off the World Health Organization's clinical management guidelines that were, I think, just given out about a week ago, being able to give some pointers. And of interest to me and ECMO, On those, it did actually recommend timely referrals to high-volume ECMO centers for consideration if we tend to see these patients infected progress. So a lot of information happening again in a very quick timeline to see how this will all evolve. So stay tuned and make sure you're watching your resources. Also does put on their front page, has already kind of published some of this information, as well as there's a commitment with the social media venues to keep real-time information out there. So probably the most dreaded piece to discuss for the clinicians that are on the line is the ECMO financial piece of it. Nobody really wants to sit and digest those elements, you know, but why is it so important for the clinicians at the bedside to understand these pieces? You know, we can keep thinking this magic healthcare money tree exists, or we can face reality. You can't turn on the TV, you can't open a newspaper, you can't click on Twitter without seeing headlines regarding the rising cost of healthcare. You know, healthcare spending is projected to go faster than the economy, increasing from 17.9% of GDP to 14.9% GDP of the GDP over the next 10 years. Government healthcare programs like Medicare and Medicaid will account for about 44% of the total healthcare spending dollars in the U.S. economy. So, you know, part of our responsibility as clinicians is to really better understand what our role can be in programs such as ECMO to try to figure out where cost containment can occur, and good decision making can help us in this larger picture. Also of note, which is again kind of those pieces that cause many of us to take note and really start to better understand the healthcare financial picture, is if you are already in an active ECMO center, you did likely hear that in October of 2018, CMS abruptly made some changes to the codes and DRG reimbursements for ECMO. This was based on advice from a consultant group that really looked and said that they believe that ECMO that was peripherally accessed would be much simpler than central access. For those of you who have ECMO clinical experience, you know that this can be further from the truth. And really, for programs like mine, hospitals were really being put in a difficult decision to try to figure out how to financially support ECMO when some of the costs and some of the reimbursement were being dramatically cut. And what ended up, just when I say dramatically cut, one of the pieces in there to note is previously all ECMO cases were falling to DRG 003, which had a reimbursement rate of nearly $105,000. With some of the new groupings that they put into effect on October 1st, 2018, the reimbursement rate was going to be roughly $35,000. So there was going to be almost a $65,000 decrease in reimbursement when performing peripheral ECMO. So the good news on this one is that the larger ECMO community united and through a loud voice through the head of CMS were able to, through data and being able to demonstrate the catastrophic effects that this would have. And so in October 1st of 2019, actually the DRGs were reverted back to 003. So why do I bring this up now and share with this, considering everything reverted back, is I really doubt that regulations as it relates to ECMO is done. I think that this was the first attempt, but I do think that there'll be continued discussions around how we can ensure that we are providing care in a cost-effective way. And so myself and others in the ECMO community understand that it'll be a matter of time before there is further discussions on how we can change reimbursement patterns for ECMO. So understanding some of the terminology as it relates, and I'll bring it to specific language as it goes to ECMO. There's obviously direct costs related to ECMO, which are the expenses that go directly into providing the service. Those things would be like labor, so the ECMO specialist at the bedside. The direct cost could be materials like the ECMO circuit, the disposable circuit that you use on each patient. There are indirect costs, so those are general business expenses that keep you operating. Those are the electricity, those are administrative costs, as well as depreciation costs, which are things like depreciating the asset over time. So that'd be like your ECMO pump, which is very costly, and an institution knows that an ECMO pump will last an average of 10 years, and so it's an accounting mechanism to spread that wealth over the cost over a period of time. So understanding those pieces, how does a practicing healthcare provider really try to digest all that and make a difference as it relates to ECMO? And there's really two places that I encourage those at the bedside to really think about, and those are those direct costs such as personnel and consumables. Your staffing paradigm, does your volume support a different staffing mechanism, meaning, if you are a 100-plus ECMO program volume per year, could you get away with having one ECMO specialist cover 2 pumps, or perhaps a single caregiver model versus having one ECMO specialist at every single system? Smaller programs, due to experience, they really do necessitate having personnel at each ECMO pump, but there's opportunities in scale and size to be able to have a different consideration. As well as with consumables, it's your circuit design and your equipment costs. So part of that is, do you always need the new shiny toy? Do you always need to have new equipment, which necessitates new disposable costs that sometimes are very costly? How much are you paying for your ECMO circuit? Are there cheaper alternatives out there? As well, I constantly question my providers is, as you're thinking about the type of support and care that you are providing, when you're thinking about patients that have failed a balloon pump and then they failed an Impella and now they're on ECMO, those are all very costly, and in consideration the escalation of care, trying to think about the mechanisms of how you want to support these patients and the cost involved in doing so. For a case study to kind of talk about what I mentioned in terms of the staffing model, a group out of Thomas Jefferson published their single site experience, and really what they were able to do is show that over a period of time, they were able to change their staffing paradigm where they removed perfusionists from the bedside. They trained ICU nurses in the new technology, which was much simpler than the previous technology, and were to have just a one-to-one staffing model, which is called primary care, where the ICU nurse took care of the patient's care needs as well as the pump care needs. And they were able to show that over the span of a year, and with training and education, they were able to remove that perfusionist and not have any significant changes in IV or ICU safety events, and were able to reduce the expenses by about 61%. So a very nice, successful model of change that's available to read a little bit more about and what Thomas Jefferson was able to do. Everyone's other favorite topic beyond finances is, what do I need to prepare for regulatory site visits? When I first got involved in ECMO in the early 2000s, Joint Commission really didn't survey too much in the terms of ECMO. Having just gone through our triennial review here, I will say on the second day of the full visit, I had one of the reviewers asked to visit an ECMO patient as well as review credentialing for those involved. So as I belabored the education piece and the credentialing piece for all the people that are involved in ECMO, this is really the impetus for why regulatory groups, whether it be CMS, Joint Commission, UNOS for that matter, if you're in a transplant program, they all want to understand how you are verifying the competence and the training of your staff involved in caring for these patients. So when you're sitting there and the Joint Commission comes in, much like I just described, and they mention to you that they want to see that ECMO patient, you've got a few options in my opinion. all of these of which went through my head when the reviewer asked, you know, what do you do when they want to see that patient? You can fake like you're having a heart attack. I don't know if I necessarily had to fake it. I definitely felt like I might have been having one. You can start frantically texting the bedside and ask if the patient can come off so that you don't have to go to the patient's bedside. You can hide your drinks and hope that that's all that the regulatory group is going to care about. Or you can take a deep breath because you've prepared and you understand what it is that they're going to be looking for. And with that, another program and a link to the ELSO website. The Award of Excellence does a fantastic job of giving you an evaluation tool that does a step-by-step approach of navigating some questions related to your physical facilities, your equipment maintenance, your staffing, your policy procedure adherence, your quality management, and training and competence. And the intention of this, you know, could be used, yes, if you've had a program in existence and you really want to showcase and navigate and show to the larger community that you're ready to receive that potential Award of Excellence. Or I really encourage any new program to pull out this readiness tool. It's about a 20-page document that really can help be the bedrock for how to set up this program and take you on a step-by-step approach to ensuring that you are thinking of all the different elements of what should be a priority as you're arranging your program. And these are the things, as you look at these, really what the Joint Commission and the regulatory groups are going to be asking about and wanting to ensure that you've thought about things to ensure you're giving the highest quality of care. So with that, I know Dr. Zakhary and I kind of definitely gave you a high overview, and I know we're happy to take any questions that have come through. So I will end with that and take any questions that are out there.
Thanks so much. I really appreciate you taking the time to walk us through both a little bit about the procedure itself and then the considerations that you really put into this work. And while we're waiting for folks to see if they have any questions, again, you can type those in the chat box. I do have a question for you, for either of you who wants to jump on it, but where do you really see the trajectory going with ECMO? Obviously, the current situation with the coronavirus is going to leave the big question, but do you see other places where this might further spread to smaller organizations and smaller hospitals?
I'm happy to share my point of view on this.
Sure.
I mean, I do think, I mean, certainly ECMO has a role in severe respiratory failure, but at the same time, I do think ECMO is going to be the new face for respiratory failure in general. Obviously, we didn't discuss clinical aspects of ECMO care, but one of the beautiful things about ECMO is that it can facilitate the awake ECMO patient. So you can have patients with non-functional lungs, and instead of being paralyzed and sedated on a ventilator for days or longer, if they're well supported on ECMO, you can stop the paralytic, wake them up, and even extubate them and start having them do physical therapy. So I think the threshold for putting patients on ECMO over time will come down and down as we learn more and more about these benefits. Certainly with coronavirus and certain epidemics that come through, there will probably be a spike in ECMO use because it's our only option. But at the same time, I do see that this will become the new face of respiratory failure.
Great. Liz, any thoughts on where you see these programs going?
I echo what Dr. Zakhary is saying, is that I'm currently, I think, about in my 15th year of taking care of ECMO patients, and each year, each surge in new patient populations, you keep thinking, where's the ceiling going to be, and is this, the height of what we're going to see, and it just keeps surging in new disease states and new ways that, we never really thought possible. And I think with the evolution of our equipment that's available to these patients, I think that's what has really allowed us to really push some boundaries and be able to help patients that we never have been able to do so before. So it's been a wild ride, and I don't see it slowing down anytime soon.
Great. We have a question from the group. Do you have recommendations on ensuring physician competence, whether it's a certain number of patients managed per year, simulations, or participation in CME? I am thinking there are probably a couple of other things you could add to that list, but what's really been the expertise you've seen?
That is the hot topic of the year, I think. That's why I really tried to stress in there that when I was mentioning the requirements around ECMO program training and competence, that really wasn't just at the ECMO specialist. That was intended at the physician as well at the bedside, whether they're managing or cannulating. We do require at my institution and have been circulating our credentialing statements throughout the ECMO community that there is a widespread adoption of requiring some type of initial training that looks a lot like the 24 to 36 hours of didactic, as well as some simulation. We require in our ELSO courses that regardless of your background, everyone is at the bedside and understanding how to navigate the mechanical and different complications that one might see on ECMO. I think the volume that you support is going to dictate how many simulations you need to do, how many meetings you need to be involved in. I'm not sure that I'm ready at this point to say a definitive number, because I think that if you do more volume and have more patient interaction, it may be a little bit less. I think for small volume programs that need for some type of case review, M&M simulations are going to be on a higher frequency.
Yeah, I think Liz summarized it well. Unfortunately, we just don't have standardized agreement on what it takes to certify an ECMO practitioner. And every hospital right now is left sort of to find their own credentialing. Typically, we require attendance at some form of ECMO course, and then a certain degree of proctored ECMO provision. In our institution, we use number of ECMO days, so you have to have a certain number of, take care of a patient with a certain number of BV ECMO days and BA ECMO days, and then CME as well for recredentialing. But I'm not sure I should give numbers because it's not clear what that should be.
Sounds like that's still a work in progress.
Yes.
All right. Well, I know it was mentioned several times throughout the slides and throughout the program, but I do want to highlight the resources that are available from the Society. They have a number of great resources on their website. I know they were linked throughout the presentation, but highly recommend you keep an eye on their website as well. They really are leading the charge on questions like this and really helping to define what this looks like in the future. It doesn't look like we have any other questions, so with that, I'm going to thank our speakers for taking the time to share this great information with our audience, and thank you all for participating, and we're adjourned.